Hello everyone. Today I will discuss a very important topic about cancer pain and when it becomes complex and different and difficult to treat. As we know, cancer pain is a very common symptom in cancer patients and it is troublesome for such patients and make quality of life very bad. If we treat cancer pain properly from the start, the complexity of such pain may be decreased to a minimum and we will success in controlling such pain conditions. By definition, it is called complex when there is failure to gain satisfiable outcome in spite of applying one or more modalities of treatment, and by time the pain becomes chronic pain syndrome. Not chronic pain, it's a chronic pain syndrome which has psychosocial element very high and lead to accentuation of sensation of pain in the cortex. You have to know that chronic pain syndrome is a real thing in cancer pain, and we face it very frequently if we don't treat pain probably at the proper time. The concept of total pain describes the final outcome of sensation of pain in the cortex, and it comprises two elements. The visible elements with the injury or the disease you see from the patient, the periphery of the patient, and the hidden factor, which are the changes that happens in the central nervous system, either in central sensitization, which may develop to chronic pain syndrome. This is very important, and this is accentuated by improper treatment of pain from the start in a multimodal, multidisciplinary, timely approach. This is the final message you will see. This will lead to more suffering. Suffering is the condition that the patient tells you about his quality of life, including pain. And when pain becomes chronic pain syndrome, the patient will exhaust his psychosocial and personal resources for coping, and he feels more pain and more disability and more suffering and more insomnia and so on. And these symptoms will increase the sensation of pain, and there is a vicious circle of pain and suffering. This is very important. We have to treat pain from all its aspects, either peripheral injury or CNS changes. And we have to prevent the development of chronic pain syndrome. At first, I will remind you about the continuum of team models. The first model is the parallel practice, in which the patient is seen by different disciplines in a separate way, and there is no connection between them. This is very bad and may lead to improper management of patient. The second is the multidisciplinary, in which there is personal connection between different disciplines conducting ideas and management programs or pathways from each discipline to another. This is okay, but the best is the interdisciplinary approach, when the patient sits down in front of all disciplines, including oncologist, including pain physician, including psychotherapist, including social worker, and they discuss the condition with each other, and they examine the patient and put a strategy for management. This is the best approach. If we add the complementary alternative medicine to the interdisciplinary or multidisciplinary approach, it will be called integrative approach, and it's very good and works in many conditions. It includes guided imaginary techniques, it includes meditation, it includes the music therapy and acupuncture and so on. Let us discuss why chronic pain or cancer pain turns into chronic pain syndrome and become complex. First of all, it may not timely applied. So the management of cancer pain must be started from the start, from the patient not feeling pain. From the patient discover he has cancer, you have to treat cancer pain by prevention, by psychotherapy, by relieving the false ideas from the brain of such patients about pain and cancer. So it's very important. It must be timely applied. And you have to address all pain generators. Your attention must not be drawn to the only one generator, which is the disease, and you cannot discover the other generators, like nerve generator, like CNS changes, like psychosocial elements, like all these generators. Don't to be astonished by that you have missed some pain generators, important pain generators, and so the treatment may be not satisfiable. And the management is not applied in a multidisciplinary, multimodal models with dynamic guidelines. As I said, it must be treated in a multidisciplinary, multimodal, and these guidelines must be dynamic according to the situation of the patient and the stage of the disease. Also, there may be insufficient continuous medical education and training programs for all stakeholders, including physicians, pharmacists, physiotherapists, oncologists, physical therapists, nursing, social workers. All these disciplines must be put in a continuous medical education and training programs, which may be repeated every now and then, and put another modalities and recent modalities to reach the typical management of such cases. There are many factors that make the pain in cancer is complex and different to treat. The famous triad, there are patient factors, disease factors, physician factors, and the treatment factors. Regarding patients factor, as we know, old age cancer is more common in old age, and these old age patients have comorbidities. The old age itself is an obstacle for applying some interventions and some models and pharmacological treatment. In addition, with concomitant comorbidities will make it more difficult. Also, the patients have false beliefs about pain management. They believe that pain is a normal process in cancer and must be left, and he must withstand, and if he take opioids he will be an addict. All these factors must be cleared to the patient and must be corrected in the beliefs of such patients and the families. Also, these patients have very high and persistent psychological or psychosocial elements. The patient, from the start, when he knows he has cancer, some false beliefs start to develop in his brain, and CNS becomes vulnerable to be more sensitive to pain if it happens. So the pain may be severe from the start from these psychosocial elements. So psychotherapy is very important from the start in the journey of cancer management to prevent pain. The disease factors may be due to original disease or due to pain syndromes. As I said, it's a heterogeneous pathology. Cancer is heterogeneous, involving many systems. Also, it has frequent associated disability like dysphagia, like persistent vomiting, like inability to put patches. He has no skin, vulnerable already for both batches of opioids, and so on. Also, the associated organ dysfunction, like liver function or kidney function, or this mobility, or all of these organs must be optimal for optimal management. So there is some obstacle in treating such patients due to organ dysfunction. The other symptoms accompanied with pain, like dysphagia, like insomnia, like depression, like anxiety, may make the patient feel pain more severe, as I said, and the situation may be worse. So the symptoms or the concomitant symptoms must be treated side by side with pain management. Also, it is a rapidly changing situation. The cancer patient may have picture today, and tomorrow may have another picture. Today you can see the patient with no bony mets, tomorrow he has bony mets. So it is very frequently changed, and the pathology will be changed, and the management will be changed. The disease factors due to pain syndromes at first mostly severe from the start. So you have the problem of starting opioids in opioid-naive patients, or to choose the interventional procedure you have to do, and so on. And it involves also multiple sites. The patient may have original visceral cancer and have bony metastatic lesions and have nerve lesions and so on. So multiple sites needs multiple interventions and multiple drugs, and there is some difficulty in tailoring such techniques at the same time. The pain may be somatic or visceral or both, may be nociceptive or neuropathic or both, and always have breakthrough attacks which need immediate release preparation to be present in all pain clinics. The treatment factors may be due to definitive treatment or pain treatment. The definitive treatment complications like chemotherapy-induced neuropathy, hand-foot syndrome, in some chemotherapeutic agents, the patient feels neuropathic pain involving both hands and both feet. Chemotherapy-induced mucositis of the mouth, post-radiation neuropathy, or treatment-induced organ dysfunction due to chemotherapy lead to multiple organ dysfunction like kidney, like heart, like liver. And in some cases, there is chronic post-surgical pain syndromes, like post-mastectomy syndrome, like post-thoracotomy syndrome, like post-amputation syndrome, and so on. This may add more pain syndromes to the original disease, and more need for more alternative interventions to treat or to deal with. The pain treatment may add to complexity. If we have some complications like opioid-induced tolerance or hyperalgesia, like persistent opioid-induced constipation, like repeated infections in spinal implants, like deafferentation pain in nerve regions, like mirror image pain and cordotomy. All these modalities or complications of pain modalities may make the management difficult, and so the complexity of pain may be more. The physician factor is very important. This is the normal scenario. The patient goes first to the oncologist, which will give him some definitive treatment, and if he has pain, he starts weak opioids. The patient still have pain, or the pain becomes worse, he starts strong opioids, not responding. In this time, he will transfer patient to the pain physician. The pain physician here may find the patient not susceptible for any intervention. He has coagulopathy, he has anemia, cachexia, disability, cardiac condition, kidney condition, he cannot deal with. So the treatment of pain by pain physician may be inadequate, and the patient develops chronic pain syndrome and becomes complex. So if we choose a model of multimodal, multidisciplinary from the start, from here, we will avoid the development of such stage. Also, the physician factors including insufficient training, no sustainable continuous medical education program, not following multidisciplinary or interdisciplinary approach, and not following the multimodal approach. This is the usual or the traditional WHO analgesic ladder. From step 1 to step 3, it is pharmacological management, and there is a proposed fourth step for the quality of life and the interventional technique. But now we treat cancer pain in a holistic continuum. It is not a step ladder. At first, from the start, the patient will take specific therapy. like radio, chemo, or surgery, and this is also treatment of pain or avoiding pain. Very important. And if he started pain, we go to drugs, nerve blocks, transcutaneous electrical nerve stimulation, transcutaneous electrical nerve stimulation, relaxation, acupuncture, and other complementary alternative medicine. It is very important. Must be applied at the same time. And this is the normal WHO Analgesic Ladder according to the severity of pain. But before applying all these modalities, psychosocial problems must be addressed and managed from the start to the end. It's very important to become the patient, or to make the patient vulnerable to other treatment. Because if you don't address this problem and manage it probably these modalities may be insufficient for such a patient. Cannot work. The multimodal approach to cancer, to summarize, is definitive treatment, pharmacotherapy, interventional approach, physical therapy, psychological support, complementary and alternative medicine. What we need to manage, we need methods of coding pain to guide us to clinical practice guideline for each type of patient, with an integrated health networks all over the country, and the patient must be seen an interdisciplinary team, and the patient self-management programming must be applied. The patient can be educated how to cope with the pain, how to do something to distract the attention from such pain. The communication is very important, with hotline support and home visits, very important, and you have to put quality indicator for your work for continuous improvement to reach the ideal situation. My message is treatment of cancer pain must be aggressive from the start in a continuum, not ladder, multidisciplinary or better interdisciplinary teams. Proper assessment and management of associated symptoms is very important. In a multimodal approach, continuous training education is a must, and thank you.